So what we will speak about here now is really the pressure laws that govern the pressure gradient, okay? So we'll talk about the movement of air in and out of the lungs according to the pressure gradient, and then we will speak about the mechanics of breathing, basically how we manipulate that gradient to make air go in and air go out, depending on what phase of respiration we're in. Okay, I'm gonna pause here a little bit and see what questions we have so far. All right, so we described this a little bit earlier, the fact that airflow is driven by the pressure gradient. And so given the fact that atmospheric pressure is not something we can manipulate during the breathing cycle, the alveolar, right, the intraalveolar pressure is the only factor that we can manipulate in order to influence our gradient and to drive flow in one direction or another. This brings us to speak about Boyle's law. And Boyle's law says that pressure is inversely related to volume. In other words, if I increase the volume of the thoracic cavity, I'm going to decrease the pressure within my alveoli. If I decrease the volume of my thoracic cavity, I'm going to increase the intraalveolar pressure, right? The pressure inside my alveoli. And we can see how that can manipulate our gradient, right? I open up or expand the thoracic cavity, which is increasing my volume. I decrease the pressure of the alveoli, so decrease the intraalveolar pressure. And so now I have a gradient where intraalveolar pressure is lower than atmospheric pressure and air can rush into the lungs. On the opposite end of the spectrum, if I decrease the size of my thoracic cavity, right, I make it smaller, I'm decreasing the volume of my thoracic cavity. And because of Boyle's law, because of this relationship, as volume goes down, pressure goes up. So volume is dropped, pressure is now risen. And if that intraalveolar pressure is higher than my atmospheric pressure, I now have a gradient in the opposite direction. So air is going to flow from high pressure in the alveoli to low pressure in the atmosphere. So Boyle's law is the basis for how the mechanics of breathing can change. As I change the volume of the thoracic cavity, I change the pressure, I change the direction of the gradient, and I can move air either in or out, again, depending on the phase of respiration. We also want to think about resistance to airflow. As someone mentioned earlier, resistance is another factor that influences, those bulk flow principles. And when we think about resistance here in the airway, it's usually involving the radius, the size of the radius. And we describe the fact that at the proximal part of the radius, there's not much manipulation there because of that rigid cartilage that we see at the proximal bronchial tree. But as we get lower into the airway, into the bronchioles and so on, we do have that cartilage being replaced by smooth muscle. And so this is a part of the radius where we can actually manipulate. We can make it larger to allow for more airflow. We can make it smaller to be more of a resistance to that airflow. And then the second important factor here is going to be mucus. And if you remember back from our bulk flow equation, this is standing in for viscosity, right? Viscosity is how thick, how viscous that particle that's being moved is. And so just as we saw in the blood, we also see a similar phenomenon here. If there's more mucus in the airway, this becomes especially important for asthma patients. They have a lot of mucus building up as an inflammatory response. That's going to be an impedance to flow. They also have bronchoconstriction because, again, as an inflammatory response, the smooth muscle of the airway constricts and it makes the airway very narrow, which is also an impedance or resistance to flow. So this is some of the kind of practical applications of how we can see resistance influencing our bulk flow of air in the lungs. So this is a different view of our bulk flow equation, right? Different but similar relationship here. Flow is going to be equal to our pressure gradient, which is the difference between our atmospheric pressure out in the air and our intraalveolar pressure down inside our alveoli. And that is divided by any impedance, any resistance, which can be regulated by the amount of mucus in the airway, as well as the smooth muscle state of the airway as well. Okay. Now, the ideal gas law is really a more general relationship as far as Boyle's law. So Boyle's law really only applies to our physiology, but the ideal gas law is a generalization of Boyle's law, okay? And I don't believe you have this text here in red on your slide. So I'm going to give you a minute to kind of write this text down, just because I want you to kind of be focusing as I explain this here. So I'll give you a minute to write that text down. All right, another 30 seconds or so. Okay. All right, so let's kind of describe this ideal gas law. So it says that PV is equal to nRT. And if we look a little closer at those variables, P is the gas pressure, V is the volume or the size of the container, N is the number of gas particles in moles. And again, just for our context, that gas is going to be oxygen. R is the universal gas constant. So 0.083 is the value, but this is a fixed value, so this never changes, okay? And then T is the temperature of that gas. Now, most of these variables are kept constant if you think about our lung physiology. The universal gas constant is kept constant. The temperature is kept constant. And then the number of gas particles is changing usually in our physiology, but for the benefit of this example, the universal gas constant is, the number of gas particles is also kept constant, okay? So let me say that again. So the temperature is constant, the R is also constant. In our physiology, the number of gas particles, the number of oxygen molecules does change. But for the sake of explaining this schematic example here, the number of gas particles is constant. Okay, I hope that's clear. So if you look at our container here on the left, we have a set size of the container. We have a set number of molecules, gas molecules in the container. And so we have V1 being the volume of that container being about 2, P1 being the gas pressure being about 1, okay? Now, again, given the fact that our temperature is constant, the number of gas molecules is constant, and our universal gas constant is constant, okay, the variables are going to be pressure and volume, all right? And what we see in the second scenario here is that if I make my container smaller, by default, my pressure is going to increase at the same proportion. Okay, so the volume went from 2 on this side to 1 on this side. And as a result, the pressure is now decreased from 1 on this side to 2 on this side. And so the relationship that I want you to understand here, right? Don't think about memorizing this or about any calculations or anything like that. It's really to underscore the relationship of pressure and volume. So as pressure increases, volume decreases. As volume increases, pressure decreases. And so that's an inversely proportional relationship. And we want to think about this in terms of our physiology. What we're manipulating is the volume of our thoracic cavity in order to manipulate that pressure. Okay, so I hope you're sticking with me. We're manipulating our pressure in order to manipulate our pressure gradient. And in order to do so, that's kind of like a domino effect. We have to manipulate the volume of the container first. So we're going to use our respiratory muscles to change the volume of the thoracic cavity. That will then change the pressure in the thoracic cavity, which will then influence our pressure gradient, okay? And so the ideal gas law is really describing the relationship between pressure and volume, the fact that they are inversely proportionally related. So as I increase volume, I decrease pressure. As I decrease volume, I increase pressure. Okay. Right. Now, the determinants of our intraalveolar pressure are going to be the quantity of air in the alveoli, so how many of those gas particles are in our air, in our alveoli, excuse me. And as we spoke about on that previous slide, in that little schematic, the number of gas particles was constant. But in actuality, in our physiology, as air moves into the lungs, the number of gas particles changes. And that is also going to influence the intraalveolar pressure as well. The second thing is going to be the volume of the alveoli, right? And that will change depending on the state of the thoracic cavity, which is increasing the volume of the thoracic cavity. And by extension, remember, the thoracic cavity is tightly adhered to the lungs. So if I increase the volume of the thoracic cavity, I increase the volume of my alveoli, and then I decrease the pressure within that alveoli. So the determinants of intraalveolar pressure is the quantity of air, the number of gas particles in the alveoli, as well as the volume of the alveoli, right? Whether they're expanded or whether they are contracted and recoiled. Okay. So someone's asking, is the temperature we are measuring our internal temperature or the external temperature? So it is the internal temperature, right? In terms of our physiology, it's going to be the internal body temperature, which should be remaining constant for the most part. Okay, good question. All right. So let's talk about kind of putting all of this together. So the lungs expand when the alveolar volume increases. All right. And what that means is the thoracic cavity pulls on the lungs, opens up those alveoli. And as I increase the volume in my alveoli, guess what? The pressure decreases according to Boyle's law. So as I decrease my intraalveolar pressure, I now have a gradient that favors air moving from high to low, from the atmospheric pressure outside to my intraalveolar pressure, which is lower inside my lungs. The opposite is true. In order to recoil the lungs, in order to expire air, I am going to decrease the volume of my thoracic cavity. By extension, I'm going to decrease the volume of my alveoli. I'm going to kind of contract them or recoil them so they're smaller. And once again, according to Boyle's law, if volume decreases, pressure increases. So now I have a higher intraalveolar pressure. And once again, that's facilitating a gradient where I have air moving from high to low, from the higher pressure inside my alveoli to the lower pressure out in the atmosphere. So it's really kind of, again, a domino series of events, or a domino sequence of events. I'm going to manipulate the volume. That's going to manipulate the pressure, and that pressure is going to manipulate my pressure gradient, and air can move either into or out of the lungs depending on the state of respiration. Okay. All right. I'll pause and see what questions we have again before we kind of reiterate that here. Okay. So just kind of explaining or describing this in another way, just so we can add some clarity here. So we're looking at the two phases of ventilation. We have inspiration, air moving into the lungs. We have expiration, air moving out of the lungs. We also want to think about our gradient, right? The fact that we have to have a pressure gradient or a pressure differential that drives air in the direction that we want to move according to that high to low pressure. The other thing we want to think about are the two factors that influence our intraalveolar pressure. Remember, the intraalveolar pressure is the only part of our pressure gradient that we can actively manipulate. We cannot manipulate the atmospheric pressure. And so the two things that influence our intraalveolar pressure is the volume of our alveoli, whether they're large or small, as well as the number of gas particles inside that alveoli, whether it's got a lot of oxygen or a little bit of oxygen. Okay, so bearing all of that in mind, let's start by looking at the state of our lungs at the top here. We also want to think about our intraalveolar pressure, which is the kind of the second panel here. And then at the bottom, we have kind of a graphical representation of how the volume and the pressure is changing. So the pressure change at the top here, and then the volume change at the bottom here, okay? So we start from a place of rest, and a place of rest means that there's no pressure gradient. In other words, there's no flow. So our intraalveolar pressure is 0. Our atmospheric pressure we know is already set at 0. And so we have no gradient. In other words, we have no flow, right? Then we gradually, the first thing that happens is we change the shape of the thoracic cavity. We have the expansion of the intercostals. So just to kind of talk about what we said in lab so far, the down and inward orientation of the external intercostals influences the way that they change the thoracic cavity. Because they're facing down and inward, they actually pull the rib cage up and out, okay? That's gonna make the rib cage nice and large, which will by extension pull on the pleura, and that will also pull on the lungs, okay? We've also got the diaphragm playing a role here. As we inspire, the diaphragm flattens out as it contracts. That will pull the inferior parts of the lung downward, again, pulling the inferior alveolar downward, really changing the volume of the thoracic cavity. That's the first factor that changes. So as we increase the amount of volume by expanding our thoracic cavity, we decrease our intraalveolar pressure, right? That volume pressure, that inversely proportional relationship, that Boyle's law that we talked about earlier. Now, because initially I am going to be moving air into the lungs, we can see that happening here, right? The air comes rushing into the lungs. That change in the number of gas particles is then going to influence my intraalveolar pressure, right? Remember I mentioned earlier, there are two factors that influence my intraalveolar pressure. One is the volume of my alveoli. 2 is the number of gas particles inside. So we're not just thinking about volume influencing the intraalveolar pressure, we're also thinking about the number of gas particles, which is changing as air comes into that alveoli, right? So as air comes into the alveoli, because of the gradient that we just described, guess what? I am now going to increase my pressure, okay? So the introduction of air, changing the number of gas particles coming into the lungs will now increase the pressure of the alveoli, the intraalveolar pressure, and that is going to bring me back to a state of 0 where I no longer see any flow, okay? So initially we have an increase in volume causing a decrease in pressure, but as the number of gas particles changes inside the alveoli, we then see that further increase in volume actually results in a decrease in pressure, okay? And I'm gonna pause there and see how we're doing with that before I explain the other half, okay? All right. So we have increased our intraalveolar pressure back to 0. So it's now the same as atmospheric pressure. This is kind of that mid-respiratory stage. Right? If you take a nice big deep breath in and you pause, there's a phase where there's no air movement because there's no gradient any longer. So that's where we're at this point. Now we're going to incite expiration. And expiration for the most part is a passive process. We're pretty much just undoing all that we did for inspiration. So those inspiratory muscles will now relax, right? The external intercostals, the diaphragm. And as the diaphragm relaxes, it's going to once again become that curved dome shape. So it's going to decrease the volume or the size of the thoracic cavity as it relaxes on itself. And that initially starts to decrease the volume. And again, according to Boyle's law, as we decrease our volume, we increase our pressure, right? It's really important to understand that inversely proportional relationship. So I change the volume of my thoracic cavity because those muscles naturally relax or recoil, changing the shape of the thoracic cavity. And so as I do that, the intraalveolar pressure will increase. I am now going to have an intraalveolar pressure that is greater than my atmospheric pressure. And so I'm going to have a gradient for air to flow outward, okay? So air starts leaving the lung according to that high to low pressure gradient. And then what we're seeing is the second factor that changes our alveolar pressure, which is the number of gas particles in the alveoli, right, in the lungs. And so as air leaves the lungs, I am now going to decrease my intraalveolar pressure because I'm decreasing the number of gas particles, okay? And we see that happening at the end of this phase here. So as intraalveolar pressure increases, it accommodates that gradient for air to move outward. As that air moves outward, I then decrease my intraalveolar pressure back down to 0, where I no longer have any flow, okay? And so I want you to be thinking about this in a holistic way, right? Intraalveolar pressure is just always changing. So if you sit quietly and you're inspiring and expiring as you're breathing, you're manipulating this pressure, and it's never really any fixed value. It's never really stuck at any one of these phases. It's just gradually decreasing, then gradually increasing, then gradually decreasing, and so on and so on. And so it's going to be changing while at the same time you're changing the amount of volume of oxygen or volume of air that is in the lung.